Now, we know that there is a high prevalence of moderate to severe calcification we encountered in daily practice. Around 30% of lesions who are treated are calcified. And this is due to mostly is associated with advanced age, systemic hypertension, dyslipidemia, diabetes, or chronic kidney disease. And this has a clinical implication of this that the presence of calcium will limit the expansion of the stent and will impact negatively the outcome, the clinical outcome. Now we know that angio alone is not enough to evaluate and quantify the calcification. We have, of course, intravascular imaging, which can provide much more details and help in the selection of strategy to use to debulk these the calcified lesions. And we have many tools, balloon-based tools like cutting balloon, non-compliant balloons, and so on. And the atherectomy, that means ablative devices. The non-atherectomy devices has some advantage with that, like easy use, relatively less complication, and work on conventional wires. But the main disadvantage that is often difficult to reach target lesion for the high profile of these devices and the reduced efficacy in severe calcification. Now, I will speak about rotational atherectomy, and I think the mechanism of action is noted for all of us. The main difficulty is to maneuver the wire of the rota wire, and this may be the next generation. That means the rota wire drive, which is new coming in the market and having the characteristics to be able to navigate in calcified lesion with one-to-one torque. This might facilitate wiring, but if you do have some difficulty to wire, then you have to wire with conventional wires, then change with microcatheter. Another good advice is to keep to avoid the guide wire bias. That means the divergence from the central axis of the vessel, and this can be sometimes corrected by the position of guiding catheter, but sometimes it depends on the anatomy, and this cannot be avoided. The other thing to be aware about, not to create looping, the looping of the wire outside of the coronary when you are pushing to advance the wire, and the wire is not advanced, then pushing the guiding catheter back and forming looping outside. And of course, the test before using the device, that means the drip, saline drip is very important to be tested. Rotation of the bar outside of the patient should be tested. The advancer and the wire should be visible, and you should be mind about the precision of the wire. Then the appropriate depth of rota wire is important because it gives more support when the wire is in depth. Insufficient depth of the rota wire will cause the pullback of the guiding catheter of the wire and the rota bar, as well as the guiding catheter will be pushed back, and this can, of course, just complicate the procedure. You should have also some feedback during ablation by visual on fluoroscopy, auditory about the pitch change relatively to resistance of the encountered by the bar, and tactile as well. When you have some resistance, you will feel it. You should not push the bar, that means avoid any daughtering, just go with the picking technique, that means advancing and coming back, and this not not more than 15 seconds for run, and intermittence. The intermittence between runs is very important to not compromise the flow. Now, indication, I think it is noted for all of us. We have seen a lot of cases done with atherectomy device here. That means every time you have undilatable lesion or uncrossable lesion, rota ablation will help in preparation this of the lesion and the bulking of the lesion. You should keep in mind that the contraindication, there are some contraindication, particularly in dissections and in acute myocardial infarction and the presence of thrombus. And there are some complications might be caused by slow flow or null flow, acute non-Q myocardial infarction, dissection, coronary perforation, bradycardia, and AV block, vasospasm, and some complication due to the device, that means the entrapment of the bar, as well as the stalling, as with attachment, or the wire fraction. Now I'll go just for some example coming to show that, that this is a case that you have seen several cases here, just undilatable lesion with balloon. Then going with rota will give you the chance to ablate. Sorry, to have a. Okay, you see that the rota ablation here is done by picking technique, and this allowing the full expansion of the stent, as you can see documented by IVUS. We have seen a lot of cases today and yesterday. This is rota in off-label indication in acute myocardial infarction. Here, the patient with the inferior wall infarction coming with the totally occluded right coronary artery. Any balloon was not crossing. So we crossed with through the microcatheter, we crossed with the wire, rota wire, and then performed rota wire. After this, the balloon was expanded. But before stenting, we went with microcatheter to see the distal flow. Distal flow was okay. And then we were able to stent, and this was the final result with TME3 flow. Another important issue is that sometimes the patient can be unstable hemodynamically, or should, like in this case, coming for acute myocardial infarction, non-STEMI, and associated with heart failure. This is angio, as you can see, severe calcified distal left main involving LAD as well as circumflex, and also mid-LAD stenosis with heavily calcified. I think in these cases, the mechanical support is very important and can help in maintaining the safety for the patient, as have been done here. The impella was placed before doing anything. Then IVUS we were able to do and to see that the severe calcification was mostly at the distal left main, and we ablated. We went for ablation, rota ablation, as you can see here. Then completed. After this, it was possible to complete the revascularization on LAD, mid-LAD with stent, circumflex, mid-circumflex with drug-coated balloon, and distal left main with double stenting with reverse tap technique. And you can see here the full expansion of the stent, the good outcome, as well as documented by also stent boost and the angio you see here. And finally, I think it is good to mention that sometimes you can have failure with the passage also with rotaplator, like in this case, due to the we tried to do the bifurcation circumflex with balloon, but any balloon was crossed to the side, to the distal circumflex. You see that there is heavy calcification and tortuosity here was not crossed by the rota. So either the rota failed to cross. In this case, we decided to only stent the main vessel and to leave the distal, that means crossover from circ to big marginal, and to leave distal circumflex without treatment, that means managed by only medical therapy. And more now, the combination of rotablation with intravascular lithotripsy is coming, and we have seen, again, many cases reported, but we do not have large cohort study to show that the benefit on long term in these cases. As well as we have a lot of algorithms how to approach the calcified lesions, but I think all should be started by, it depends on the entity of the calcification, that means if moderate or severe. And then I think if you do not have any access to the lesion, rotablation is the first, is the upfront technology to use. So optimal lesion preparation with plaque modification is the most important step to achieve optimal result in with the stenting. And the presence of calcification can increase the risk of complication in complex angioplasty. Different devices dedicated for plaque modification and preparation before stenting are available. Good experience and knowledge and specific devices help for an appropriate selection, good, safe, and effective use. And in severely calcified lesion, at the present time, still rotational atherectomy considered the first option, also in combination with other devices. Thank you very much for your attention.
Thank you, sir, for your excellent. Is there any question from audience?